Hi, everyone. I'm Dr. Mohammed Samji. I'm introducing Dr. Gavin Britz. Dr. Gavin Britz is professor and chairman of neurosurgery at Houston Methodist Hospital and director of the Methodist Neurological Institute. Uh, he leads an acclaimed team of neurosurgeons and affiliated professionals and is recognized as one of the nation's foremost cerebrovascular and skull-based surgeons. Dr. Britz is one of the most experienced surgeons for brain aneurysm procedures, including complex cases that require cardiac standstill or complex bypasses. He treats brain aneurysms using traditional microsurgical techniques, but he also performs endovascular therapy with coiling and stenting of aneurysms and has training in both neurosurgery and interventional neuroradiology. He specializes in the treatment of AVMs, dural AV fistulas, arterial dissections, atherosclerotic disease, moya, and skull-based disease. He treats brain tumors such as meningiomas, chordomas, pituitary tumors, craniopharyngiomas, vestibular schwannomas, and also performs MVDs. He is among the first surgeons to test and use the latest devices for endovascular therapy. He came to Houston from Duke University Medical Center in North Carolina, where he served as director of the Cerebrovascular Center and associate professor of neurosurgery. Earlier in his career, he was co-director of the Neurological Surgery Unit and director of endovascular neurosurgery at Harborview Medical Center, while serving as associate professor of neurosurgery and radiology at the University of Washington School of Medicine in Seattle. He leads basic science and clinical studies to understand stroke causation and evaluates novel tools to treat brain aneurysms and skull-based tumors. He leads the Department of Neuroprosthetics, funded by the Department of Defense. He's on the advisory board of the Joe Necro Foundation and the Brain Aneurysm Foundation. He serves on the editorial board for Neurosurgery, World Neurosurgery, International Journal of Vascular Medicine, Surgical Neurology International, and Dataset Papers in Medicine. So with that, I'll turn it over to Dr. Britz for his presentation.
Right. All right. So first of all, thanks very much for inviting me. As you guys everyone knows, I've got very close ties to Seattle. I spent my formative years there, and I think Mohammed, we share a little bit of a history in that. I spent some time in Manitoba as well. So I think some people have heard some of this talk before, and but I'm going to just go into a little detail. And what I'm going to focus on today is talking about what is the cognitive declines post subarachnoid, which we see. And just as a background, for the background slide, as you can see, this is the Texas Medical Center. All the buildings you can see are now Houston Methodist, and that can just see the example, of how big we are. So obviously, it's a part of me to brag about a department. So to people that don't know Methodist, I think, as you know, we were a community hospital in 1919. Started as a 30-bed hospital by Noseworthy. After World War II, two big philanthropists donated money to develop the Texas Medical Center. And the deal was that they could pay no rent or $1 rent a month, a year, and they can have free rent in this Texas Medical Center. And that resulted in all these big universities moving to the Texas Medical Center. And there's nothing like it in the world. I think that people haven't been here should come here and see what it is like to be with in this major medical center with multiple universities, multiple hospitals, all competing for each other, but all doing pretty well. The Methodist itself was started as a 3-bed facility in 1951, and then was a teaching hospital for Baylor Medical School, and then it was always ranked as a top 10 university hospital. And then we split with Baylor in 2004. We then independently, we were essentially a private hospital with no university. We then formed Weill Cornell, and now we are Weill Cornell affiliate. But we've grown from then, and now we're affiliated with both Rice University as well as Texas A&M. And we've grown in the last 16, 17 years now to be known as one of the top hospitals in the USA. Just for the department, as you can see, this chairmanship has really aged me, but there's actually been only 4 chairs in the Methodist hospital system. James Greenwood was the guy that actually invented the bipolar, was the chief of neurosurgery before. George Eney was the chair of both Baylor and Houston Methodist for many, many years. Actually, he retired. He basically went into private practice after his chair at 65, diagnosed with pancreatic cancer, and was dead within 6 months. It shows you don't delay life. And then, as you all know, Bob Grossman died recently. He was a chair here for many, many years, and I've been chair here now since 2013 and look a lot older already. So this is the department. It's a pretty big department. We have 22 academic neurosurgeons now in the department. We also have 7 private neurosurgeons operating here. We have three critical care faculty, a couple of paramedical staff. So we have 57 faculty now. And regarding volume, we do over 4,000 open cases at the TMC campus alone, just under 1,500 endovascular cases, 220 radiosurgery cases now. And with the system, we're doing just under 10,000 cases now. And our volume is going up. And I know my personal volume of the last year has really skyrocketed. So I think by the end of next year, we should definitely be over 10,000 cases a year, and largely is open neurosurgical cases itself. That's what we look like. I showed you the slide initially, what it looked like at night. That's if you look at the slide on the left, that's where neurosurgery is housed. We share this building with the heart center. That's what it looks like. That's what our outpatient center looks like. We have 7 dedicated operating rooms that run 24/7, intraop MRI between 2 rooms, 36-bed ICU, gamma knife system, 3 interventional rooms. This is all just at the medical center as well. So as you can see yourself, it's a big clinical machine. For education, we have the Mighty. We don't use it as well as we should for neurosurgery, but it's a big building with dedicated teaching rooms. We actually have an intraop MRI for the animals there, intraop angio. We have all the robots that we can practice there as well. So Memphis is well suited, to take on the future. So I'm going to start my talk now. And just as you guys know, I'm largely a skull-based surgeon now, but I used to be a vascular with a change in endovascular, but I still do a lot of vascular. So I've always had a big interest in brain aneurysms. As you all know, 1 in 50 people have an unruptured brain aneurysm. The rate of rupture of aneurysms is really unknown, but basically thought to be about 8 to 10 per 100,000 people per year. About 30,000 people have a subarachnoid hemorrhage every year. Women more likely than men to have aneurysms. African Americans and Hispanics twice as likely. And about 15% of people die before reaching the hospital. This is actually a better number than it used to be. When I trained in Seattle, about the data that time showed that 1 in 3 people died from an aneurysm, but it's definitely better. And we're actually looking at the reason people die with aneurysm right now, which we won't talk about this talk, but we're looking at the cause of death at the moment. And I think that, about 1/3 of people still die, but that takes into effect the treatment complications as well as the vasospasm infection and the delayed neurological deficits. When I trained, success after a rupture aneurysm was defined as patient survives, moves their limbs, goes home after rehab, and we did all these bypasses. And I think that things got better early on, improved magnification, including developing the microscope. I think neuroanesthesia really improved a lot in the last 25 to 30 years. We used lumbar drainage, we did neuroanesthesia, we did the skull-based approaches, we used temporary clipping, we did intraop angiography, and refinement of the microsurgical techniques. So this clearly made a big difference in the outcomes of ruptured aneurysms. I think this was actually taken a whole step further by the development of the endovascular therapy for aneurysms. As we all know, the first coil was used and the catheters resulted in us to be able to access the whole vascular tree. This resulted in coiling of aneurysms, stenosis of coiling aneurysms, and even now flow diverters. And this evolution from refined microsurgical techniques to the endovascular techniques has even further improved the outcome for people with aneurysms, particularly unruptured aneurysms, but also subarachnoid hemorrhage. We're still pushing the frontiers. As you guys know, we do a lot of robots here at Methodist, and this is a couple of the articles we published over the last 2 years. So this whole endovascular arena is moving forward. As I said, microsurgery is still an important part of the practice of aneurysms, but I do think it's going to be moving forward from endovascular to robotic assistance, and I think this is even going to change the outcomes further. But to take a step back, I think when you look at your people post-subarachnoid hemorrhage, if you look carefully enough, 95% of people still have what is now called a post-subarachnoid syndrome. So the people that can go home, they move their limbs, they can talk, there's no major strokes, but when you really look at them during neuropsychological testing, 95% of people say, I'm just not the same again. I have emotional disturbances, I've impaired memory, decreased executive function, language complications that you don't really recognize on a basic neurosurgical examination. I think it's important to realize that over half the cases of subarachnoid occur under the age of 55. So you have a population with these deficits that has a long life expectancy, and they're unable to contribute to society, but also cannot enjoy the latter years. And I think when you look at the hazard ratio of developing dementia following a subarachnoid hemorrhage, it's the highest of all the stroke models. So your hazard ratio of getting dementia after subarachnoid hemorrhage is 2.74 times population, which is even higher than ischemic stroke for dementia, which is only at 1.72. So clearly this paper for me was a great paper that showed that the work is important, and we still need to figure out why people develop dementia, why they're not the same again. And this can also lead into why people with post-traumatic subarachnoid hemorrhage also have significant chances of developing dementia. There's also been clearly shown evidence of morphological changes in the brain. That's been well described. You get general brain atrophy, including the temporal lobes. That's not new. It's been well described, but we don't completely understand what's going on. So I think that for me, I've always been interested in the cognitive aspects of subarachnoid hemorrhage, but no one really understands the actual mechanisms. And without understanding the mechanisms, we cannot understand and create new treatments. So when I started this field, I'm getting an old man now, a little younger than Jens, but not more. But I think when the previous research, when we talked about it, even in Seattle days, what was the cause? It was always to do with strokes. Okay, stroke, people call strokes, it was vasospasm, and that's why the people are not the same. But when you really look at the data, even those days, and it's got better these days, 1 in 5 subarachnoid survivors only had vasospasm, yet 95% of sufferers had dementia. So obviously there was a problem with that hypothesis that it's all large vessel vasospasm. And that resulted in the focus on the microcirculation. And I think the current clinical data supports that hypothesis, that it's not just the large vessel, that it could be the microcirculation. And I think you look at Gerald's paper in Stroke in '84 showed ischemic deficits that were present in the absence of vasospasm. There was evidence of hyperresponsive peal arterioles within 8 hours of subarachnoid hemorrhage, which was primarily in stroke in '98. And there's even a more recent article that showed evidence of microvasospasm in humans following subarachnoid hemorrhage from Germany. And I think that one of the big papers that clearly showed this, that there was small artery strokes in the peripheral region that was detected on MRI scan following subarachnoid with people with no evidence of large vessel spasm. So clearly the microcirculation does play a role in this poor outcome. And it makes sense. Why does it make sense? If we know that subarachnoid hemorrhage does alter subarachnoid function, peel and penetrate, and I'll show you that later. This results in abnormal reactivity, abnormal vas communication, abnormal regulation of CVF, which obviously will cause the small vessel strokes, but also result in worsening effects of the large vessel vasospasm and resulting in morbidity. So this started in Seattle, and I'm going to show you the progress of my lab stuff, and you'll see it becomes a lot more sophisticated near the end. But when we started in Seattle with just like one person, Joe Meno, in my lab, we said, well, let's try and define if it's true. So the question one at that time was, is there normal peal arteriolus reactivity following subarachnoid hemorrhage? As you know, the blood supply to the brain comes from the surface and it dives deep inside. So we used the endovascular filament model, perforated, stimulated the sciatic nerve, and just looked at very simply what is the reactivity of these peal vessels post subarachnoid hemorrhage. And we published that in Stroke, which clearly showed that these peal vessels were completely abnormal. Not going into details because we're not talking to a basic science audience, but nitroprusside, adenosine, etc., all were supposed to attenuate, well, actually cause extra dilatation of the vessels, couldn't do it. So these were clearly abnormal. They never responded to normal mediators of the control of the peal arterioles. We then said, well, the peal arterioles are important, but that's not the real end game. Let's look at the penetrating arterioles. And this looks like a pretty simple experiment, but obviously when you do it, it's pretty complicated. We do the same thing, subarachnoid models. We then take the penetrating arterioles that go into the brain from the surface of the brain, load them up in a pipette, and create a laminar flow. And then we provide a whole lot of vaso agents and agents to to this bath, and we again evaluate what is the caliber of this vessel in regard to subarachnoid hemorrhage. And this was published as well, which clearly shows the same thing using different mediators, ATP, adenosine, sodium hydroperoxide, and cyclic GMP, which clearly showed, if you look at this slide, at 2 to 4 days post subarachnoid hemorrhage, these penetrating arterioles, much like the pedal arterioles, were completely abnormal in function. They couldn't respond to the normal vascular stimulus of supply versus demand. So when you stimulated them, they couldn't do it. So at that time, we agreed with, and we were actually one of the first people to think about the microcirculation, obviously beyond the MRI studies. We had clear evidence that at that time, both the pedal and penetrating arterioles from the microvascular responses were completely abnormal. And again, not going into details, this was significantly depressed for 2 to 3 days following subarachnoid hemorrhage. So that started my journey into the research. I'm mainly a clinician, but I do have a lab, and I have a lab that's getting bigger by the day. But that was the start of my research, clearly showed the microcirculation is abnormal in subarachnoid hemorrhage. Well, I think we all know that the corrugation of the internal elastic lamina was important for subarachnoid hemorrhage, and no one had clearly demonstrated that this was found in the small arteries. And you look at the basilar artery, the middle cerebral arteriole, we also found corrugation of that. So not only now did we find that it's a functional problem with these vessels, there was also an anatomical problem with the vessels, which supported why there's something called microvascular vasospasm. So what did this mean at that time? And this is about, unfortunately, already 14 years ago. There was growing clinical evidence from all the studies I showed you before, together with experimental evidence from my lab, suggesting that the cerebral arterial function is compromised following subarachnoid hemorrhage and may account for the subarachnoid-induced deficits. And these deficits can obviously explain problems with executive function if you get a lot of subcortical strokes, and obviously interfere with blood supply to the hippocampus. I was fortunate enough to train in Seattle with George Ogerman, and we had a large epilepsy program. So a lot of us had an interest in the hippocampus. We exposed a lot of that type of surgery. And so obviously we started thinking about executive function more than the other program people did, because we were in this great program. And as we all know, hippocampus is a core region of the limbic system. It has widespread connection to the cortical areas and subcortical areas, but also it's one of the areas of the brain that Coyle described in the 78 that has got sparse vascularization and is very vulnerable to ischemic injury. So this study was, the Coyle's original work was looking at people with post-traumatic ischemia and hypertension, which showed that the hippocampus is very vulnerable to ischemia. So when you put together what we found with the microcirculation in subarachnoid hemorrhage, it's very plausible that if you have abnormal microcirculation, that's going to result in ischemia to the hippocampus. So that was my working hypothesis at that time. So I left Seattle and went to Duke, and unfortunately for the first 2 years, was just operating like a madman, and didn't have a lab going, but then started working with the epilepsy guys and said, look, if we have this data now that clearly shows these vessels are abnormal, but I didn't have the time and expertise at this time to actually look at the blood flow in the hippocampus. So Dennis Turner was our epilepsy surgeon there, and he had a model that said, Gavin, we can look at it indirectly and see what the blood supply to the hippocampus post subarachnoid hemorrhage. And if you look at the slide on the left-hand side, that's the hippocampus. And what we'll do is we'll stimulate a certain part of the region and then measure simply by oxygen tension about 2 to 3 millimeters beyond in the hippocampus. And if you look at the slide below, the baseline oxygen tension was, as expected, just over 30. We stimulate, which increases the demand, and classically as expected, the oxygen tension goes up, and then it slowly goes down. And we do it inside and outside the stimulation region. We found the same thing. So the big question is, how is this going to respond to subarachnoid hemorrhage? And then we did the same thing with subarachnoid hemorrhage, and that's a train. But if you look at the right panel here, when we did the baseline oxygen measurement, it was 100. So that hippocampus was not hypoxic post subarachnoid hemorrhage, but was hyperoxic, meaning that there was abnormal regulation of the whole blood supply to the hippocampus as resulting in the cells being exposed to toxic levels of oxygen. And what happened when we stimulated the train, instead of going further, we actually found a dip, okay? So that was a significant finding, which showed that the hippocampus itself is vulnerable to ischemia. But unlike what we expected that you'd find hypoxia in the hippocampus, we found that hippocampus actually had elevated oxygen tension relative to normal, and that went down when you stimulate it. And we did the same thing in vitro, going to the same situation, and we published this, which showed that the hippocampus post-subarachnoid has a complete dysregulation of oxygen hemodynamics. So that's where we were at that time when I was at Duke. And obviously this takes you may not have seen that, but that takes a lot of work to get that stuff done. So when I came to Houston in the basic science lab, I moved it over and said, fine, we'll get it going now. So up to this time, as you can imagine, we clearly showed from the lab the microcirculation was affected. We clearly showed that the campus had completely abnormal oxygen reserve, and the blood vessels, the microcirculation did not function well. But what we found was that there wasn't cellular loss. So I think that when you look at the data from Locke McDonald, who looked at this work before I did, there was no cellular loss in the hippocampus. So if you believe Coyle's data, you should find hypoxia should result in CA1 cellular loss. We never found that. So we found all this microcirculation abnormal, but we said something still doesn't make sense. So the hypothesis we did here, which we'll show you a little later, was, well, how about this? How about that subarachnoid hemorrhages results in damage to the entorhinal cortex, which then triggers the degeneration of the campally projected perforant pathways. As you know yourself, where I'm showing you now on the slide, that's entorhinal cortex, which leads into the hippocampus, and that will result in hippocampal atrophy and not cellular loss, and we predicted this as myelin. So obviously, when you look at the microcirculation itself, this cannot explain why you get no cellular loss, but you do get loss of myelin. So obviously, that research had to take a step back. I said, this doesn't make sense. So we said, well, let's look at a different mechanism. And obviously, as we know, as we get older, we all start looking at ways to keep ourselves looking younger. And inflammation plays a major role in keeping us young, keeping us healthy. So we said, well, what's the innate mechanisms of inflammation in the brain? And that's the complement system plays a major role. As we talk to neurosurgeons, we're not into the details, but as you know yourself, the complement system is an innate mechanism that controls inflammation. And we propose that subarachnoid hemorrhage, via the mechanism unknown, activates this complement system and results in hippocampal cell loss, or not cell loss, hippocampal injury, that then results in loss of executive function. So to take a step back, we said, fine, we knew this, but obviously we knew it in humans, and a few people had shown in a non-rigorous fashion that post-subarachnoid hemorrhages, the mice were affected. So we went back and spent a year, and it's largely Angelique, our first author in the lab, took about 300 mice, did the subarachnoid hemorrhage, and without going into detail, we did this detailed evaluation of different memories and learning abilities of these mice, and clearly found that in this population of mice, there was a completely abnormal memory and executive function. And this is now currently in press in regard to translational research. So we then said, okay, so we have the data now that the hippocampus is not working, the microcirculation is not working, we think it's complement, let's evaluate complement. So we said, well, first, before we do that, let's just do a screening test. And I think that people that do transcriptome research, we actually work with Cornell people, and we took these mice, took their brains, and we did a transcriptome analysis of all the different genes that were upregulated and downregulated, and we published this, looking at what's going on, what is the underlying driving force of the changes in the hippocampus. And again, just without going into details, but what we found was that there was suppression of the oligodendrocyte myelin-related genes and overexpression of the genes related to the complement system, along with genes associated with the innate and adaptive immunity. So now, for the first time, we said, wow, this makes complete sense. You get fine hippocampal atrophy, but you don't find cellular loss. So what's the only way the hippocampus can actually get smaller with not losing cells? And it must be related to myelin. The second thing we said, well, why is the myelin dying? And we said, well, it must be the complement genes were upregulated. It must be what we thought, that the complement is activated and results in the loss of myelin of the neurons in the hippocampus. And that's exactly what we found. To go into details, we found complement, particularly C3, being very activated in the entorhinal cortex, as well as the hippocampus. And as you can see, these are the perforant pathways, getting back to what I said earlier. But also more importantly, you look at the slide at the top, we found dendritic pruning of the neurons and axons in the hippocampus from a complement, and we also find LTP suppression. And then we looked at the localized increase in complement, and as you can see yourself, the complement, particularly CA3, was very elevated in the hippocampus and different layers, particularly a cellular layer, molecular layer, radialis, and granulosa. And we found hippocampal atrophy, which we've got a real good software mechanism now, and we found this inflammatory response in regard to the hippocampus. So now we're in a situation where that we believe that subarachnoid hemorrhage damaged the entorhinal cortex. As you can see, we can find increased complement in the entorhinal cortex. We can find cell loss in the entorhinal cortex. And this triggers the degeneration of those perforant pathways that are projecting into the hippocampus. This results in secondary damage to the hippocampus, which includes the loss of dendritic spines, which you showed, the suppression of long-term potentiation, the development of the behavioral deficits, and also we find localized increase in hippocampus levels of C3 and complement, and this results in the hippocampal inflammatory response and hippocampal atrophy. So getting back to that, as you can see yourself, that's the perforant pathway. So where we are now in regard to this mechanism, we're one of the first people to clearly show and understand why people in mice, not humans yet, have hippocampal atrophy, but not cellular loss, and why they can potentially have the executive malfunction. So this is where we are now in regard to this work. We're just putting a grant now again to take this further, looking at how we can try and modulate complement. And we're working with rice engineers now to try and develop electrodes to try and prevent injury to entorhinal cortex. And we believe that with neuromodulation, you can modulate the amount of cellular loss in the entorhinal cortex and also then prevent the degeneration of these of the axons into the hippocampus, and maybe change the way subarachnoid hemorrhage causes dysfunction in humans. The other part of my lab is looking at CSF flow and G-lymphatic flow. And I think that, we're neurosurgeons, but this is a part of a talk that I give to some of the basic scientists. As we know, you get bleeding in subarachnoid space from a rupture aneurysm, results in that subarachnoid hemorrhage. And so what I'm actually interested in now, in addition to the complement, in addition to the microcirculation, is a G-lymphatic system pathway. And the Department of Defense has just given us a big $3 million grant to look at this in normal humans, but obviously this is very related to the work we do in subarachnoid and animals. So people that don't know what G-lymphatic system is, I think CSF, I believe it's a continuum, but CSF comes inside the artery and it goes into the interstitial spaces. And it's that space, the spinal fluid space around these small little vessels that then diffuse into the interstitial space, that then is the G-lymphatic flow that then is transported by different mechanisms, which we're busy working on, into the veins, into the face, etc. And that's the system that is believed by Niedergard and Iffel from Oregon, that clears the brain of the waste. So I think that we will all hear about this more in the future. And I think it's an important pathway for young investigators to get involved in. And I do think that this may result in a Nobel Prize for Niedergard, who described this the system. So we've taken this further and we say, well, how does subarachnoid hemorrhage affect the CSF circulation, much the G-lymphatic flow? And again, you can see the same thing. And what we did is we took microspheres, we injected in the cystostomagmy in rats, and trace them throughout the G-lymphatic system. And to show you the results here, that's what a naive looks like. We inject the microspheres without subarachnoid, the dorsal ventral part of the brain. And as you can see here, it's not very complicated research, but you can get complete, I can say the whole subarachnoid space fills up, and you get CSF flowing along all the perivascular spaces. And that's what we found in normal rats. When you take the subarachnoid rats, again, using different sized particles, particularly in the larger particles, what we found was you get a complete arrest of spinal fluid flow in these rats. And this is not the type of spinal fluid arrest that you find from Hydrocephalus, from a large capping of the ventricles. This is a small amount of blood. So this is, we're not talking about Hydrocephalus from mechanical obstruction. As you can see, this is a small amount of blood we inject with these microspheres, and even with a small amount of blood, you get complete arrest of the CSF flow. Not the extent that they develop hydrocephalus, but there's obviously an alteration of the G-lymphatic flow. And the same thing looking at bulk flow down the spinal cord in a normal rat, in the sham rats, when you look at the subarachnoid hemorrhage, you get a complete abnormal G-lymphatic flow in these rats. So there's no doubt that the G-lymphatic system is affected by subarachnoid hemorrhage, and is probably related to some of the poor outcome as well. And we published this recently in JCBF and that showed this whole alteration of flow. But also, which I'm not showing you now, it's showing you now, we can also modulate the spinal fluid flow. When we took tissue factor and we blocked tissue factor, we can actually increase CSF flow and decrease the CSF flow by just adding a blocker. So that tells us in the lab that the G-lymphatic flow is probably related to, it has a, well, not complete related, but there's a significant molecular component to the regulation of CSF flow. I think if you ask most neurosurgeons what drives CSF flow, most neurosurgeons will say it's the heart, it's the respirations, which is true, gravity, etc. But we believe that the molecular mechanism, particularly in the glia limitans, plays a significant role in how the body regulates CSF flow, and also in the same way regulates CSF and G-lymphatic flow. So I think that this is a really cool stuff. And I think that what I'm going to show you now is probably the biggest significant finding that my lab has done in life. And if you ask most neurosurgeons and even most scientists, where do you find fibrinogen? I think, as we all know, fibrinogen is a substance that results in the final mechanisms of blood coagulation. And if you ask everyone, including myself, before we found this, I'd say fibrinogen is always found in the intravascular space. But what we did when we stained those mice in that previous experiment, we did find that we found fibrinogen aligned on the surface of the brain, particularly in the glia limitans, which suggests, and all the chains of fibrinogen, which suggests that, hang on, this is not purely intravascular. And we're not going into details, but we found this, in the area at the subarachnoid hemorrhage, but also found fibrinogen outside the subarachnoid on the glia limitans, away from where we create the subarachnoid. And again, we look at regulation of CSF flow, same thing. We found the fibrinogen was laid on the glia limitans, which is a part of the brain. It's not in the intravascular space, and we could find all the change of the fibrinogen on this brain. And then we stained it. We said, okay, well, is it only on glia limitans? Is it only on the lining of the CSF pathways? And we actually we stained the dentate gyrus, which clearly showed fibrinogen was expressed in the dentate gyrus. We then found that fibrinogen was expressed in astrocytes. I'm going to not into details. And in addition, we found that fibrinogen is expressed in cortical neurons. And we found this is just a study of show that it's in both. And this we just published now recently in Friends of Neuroscience, which showed for the first time that fibrinogen, which was believed to be an intravascular product, actually is produced by astrocytes as well as neurons, as well as the glia limitans. So therefore, it supports the theory that we have that CSF flow is partially regulated by molecular mechanisms. And I think this whole G-lymphatic pathway is important, but it's important that we can probably develop a drug long-term that can help people with G-lymphatic problems. So I think that this is obviously a short little talk, but as you can see from yourself, this is to a neurosurgical audience. I think when you look at post-subarachnoid hemorrhages, cognitive disabilities following subarachnoid hemorrhage is multifactorial. I think we all know the common causes, which is the acute hydrocephalus, the strokes from the treatment, large vessels vasospasm. But I do think that for the younger generation of neurosurgeons and neurologists, we have to continue looking at the microcirculation. I don't understand completely how the microcirculation has changed in the hippocampus in regard to becoming super hypoxic. I think the abnormalities of G-lymphatic flow are going to become more and more important in the future, particularly with subarachnoid hemorrhage. I think from Peterson's work in New York, information is going to play a role in addition to the microthrombi, but I think the complement is going to play a role. But I also believe that the subarachnoid hemorrhages damage the entorhinal cortex and triggers this whole degeneration pathway, resulting in myelin loss related to complement that results in atrophy. And I think this is just to share a quick lab. And I think that all this lab work, I have a small lab, not a huge lab, but Joe Mena from the University of Washington started this with me. Obviously, Dr. Wynn helped me get this going in regard to the penetrating arterioles, the perforating arterioles. Rich Ellenbogen supported support. I think Dennis Turner provided an influx into my enthusiasm for the research by showing the hippocampal slices that the microcirculation was abnormal. I think my two PhDs in my lab now, Gene and Angelique, have been phenomenal. I obviously been funded by multiple sources, and that's what I do for a living part-time. I got this big tractor, 613M series at a farm in Houston, Texas. So in summary, and I'm open to questions. Obviously, some of the stuff we're working on now, but I think the resulting cognitive deficits following subarachnoid hemorrhage is multifactorial. I think the complement is going to play a big role. G-lymphatic flow is going to play a role. Microcirculation is going to play a role. And we are trying to develop treatment modalities with Rice University, how we can modulate this now with neuromodulation while we're developing the drugs and molecular therapies for these pathways. Thanks.
Hey, Gavin, that was a great talk. It's Rod.
Hi, Rod. How are you?
Good. Hey, so I remember when I was a medical student and you were the chief resident at Harborview, and I remember you and Jens were there all the time, operating day and night. I was telling Jens that story yesterday.
So Rod, I've got a weight training down do now, another angio. I do 600 cases a year. So that's why my lab work, it's quality over quantity. You know, as you can see yourself, there's some, you know, obviously I do a lot of clinical papers, but I think for me as a busy neurosurgeon, I have to focus on quality and making a huge difference in the lab.
Well, and you know, Gavin, this is really fascinating to me. You know, as a neurosurgeon, you know, obviously I don't do any cranial or vascular work, but the work you're doing is absolutely amazing because for me, you know, this is a huge problem and it's one that I never understood. Like, I remember even when I was chief resident, you know, when we're in New Zealand and Virginia, you know, you would see these post-subarachnoid patients and they would get atrophy. You could see their ventricles blow up, right?
Yeah. And
you could see the hippocampus shrink. And then you're like, do they have normal pressure hydrocephalus or do they have cortical atrophy or what the heck is going on? And here, you know, they are in the hospital for 3 months and, you know, and they have every complication you can think of. And then, like you said, they're just off. And to me, what's fascinating, Gavin, is, do you think, is there a way, can you tell the difference between someone who has normal pressure hydrocephalus or communicating hydrocephalus or this, you know, atrophy of the hippocampus? Because it's
so that is exactly, so that is a really, so I mean, that's one of the best questions I've got ever since I was giving these talks. Okay. And it's a continuum. So one of my research, clinically interested in NPH, and I'm a skull-based largely surgeon and a part-time vascular surgeon these days, but the field has changed. But I see a lot of NPH patients, and the reason I do is for exactly that. So I believe it's a continuum. Okay, I think that when you look at there's hydrocephalus from mechanical tumors, et cetera, and then you get the Alzheimer's, and then you get the normal pressure hydrocephalus. And I think if you look at even for Alzheimer's, there's a big overlap between people that have Alzheimer's and have NPH. And I think there's a continuum. And I think when you look at the hazard ratio of post-subarachnoid patients, they get dementia, okay? Much like an Alzheimer's. It's obviously dementia. Alzheimer's is one of the causes of dementia. But we believe that people with NPH usually have a remote history of trauma, which means they have a little bit of blood in the subarachnoid space that can trigger, much like we're seeing now with the post-subarachnoid patients that then develop NPH. And that's clearly been shown. If you have a history of trauma, the chance you developing dementia is higher, and the chance you developing normal pressure hydrocephalus is higher. So I think that, as you know yourself, Ron, from the UVA days, 1 in 5 people develop hydrocephalus post-subarachnoid in a delayed fashion. And what I feel that is an exaggerated course of the development of subarachnoid, of normal pressure hydrocephalus in these people. And it's the same mechanism. We are trying to work that out. And I think that as my lab has changed from from just microcirculation, and complements a big part of the lab as well. But I think the funding now is allowing me to look at the G-lymphatic flow. And I think that, when you look, whoever does a adenosine, you do the adenosine, stop the heart, you restart the heart, the CSF just pours into the field, So I think that the circulation, there's little oscillations, as people talk now, the B waves do result in CSF flow, which is abnormal. But I think it's more than that, Rod. I think that there's a molecular mechanism, and I think tissue factor, et cetera, all plays a role in how people then develop this normal NPH. So I think, to answer your question specifically, I think this post-subarachnoid delayed hydrocephalus is a variant of what we call normal pressure hydrocephalus. And I think if you go to most people that develop NPH, they either have a history of remote trauma, or they have an abnormal tissue factor or abnormal glial limitans that's resulting in their problem, which is good and bad. I think the good thing is we can treat it now with a shunt, but long term, we want to give a drug that will help to modulate the way how the system works.
That's great, Gavin. We're so proud of you. And I know you're still a big Mariners fan, and we have a hockey team, and Jens and I are trying to get the Sonics to come back. So
yeah, one of the reasons I'm off professional sports because the Sonics left. I
yeah,
they have no loyalties. I always tell people,
I know that.
The guy said, you're not a sports fan. I watch golf. Yeah, golf's an individual sport, and tennis, because sports teams, they just leave whenever there's money.
Yeah.
So I completely agree with you. Yeah.
Well, keep up the great work. We're huge fans of all the stuff you're doing in Houston. I think Mohammed is there's some great questions Mohammed's gonna go through here. Keep up the great work, Gavin.
Thanks, Rod.
Mohammed, are you still on?
There's a few questions here.
Yeah, great. Thanks, Mohammed.
The first question is, can you share your thoughts on the use of IV heparin in relation to some of the topics that you were discussing?
Using of heparin. So obviously, heparin, there's two functions of heparin. One is obviously as anticoagulant, but the other reason for heparin is anti-inflammatory. So I think that's what this question's about. I think that no one knows the answer, but I think it plays a huge role as an anti-inflammatory agent. And I think particularly from the Josh Peterson's work up in New York, I think preventing the microthrombi, heparin will definitely use that. So do I use it all the time? No, but I use it as quick as I can in my post-op patients and post-subarachnoid patients. I do use it. But I think when I use heparin, I think I use it for multifactorial reasons, not only to thin the blood, it's an anti-inflammatory as well. So it definitely makes inflammation in the brain better.
You're using this on a day-to-day clinical level?
Well, I mean, people, we use, I don't prescribe it to for inflammation, but when people post-op day 2 for DVT prophylaxis, they get heparin. But I know that I'm giving the heparin for more than the one reason of preventing DVT prophylaxis. I'm using it also as an anti-inflammatory. So I think that's the way. Hold on. Are you there? Sorry, yeah, Mom. That's how I do it. So I just, it's not. We don't. You can't legally do it. But I know when the patients give the heparin, it's another way I'm helping the inflammation and preventing those microthrombi in the hippocampus.
The next question is, trials for vasospasm have failed to show improvement in clinical outcomes. So given that, do you think that showing improvement in outcomes with any kind of therapeutic is going to be difficult, given that there's several mechanisms involved, as you said?
Yeah, Mohammed, that's a really good question. If you look at all the calcium channel blockers, modipine, it's been shown to, in some degree, make a difference, but not significantly. And I think what it tells you is that we haven't understood the mechanism of what's causing all these problems. And I think what I've shown in my lab is it's multifactorial. And I think the reason nimodipine works is not because of the change the microcirculation or the large vasospasm. It's a calcium channel blocker, and it prevents a secondary injury from whatever causes the injury initially. The calcium channel blocker has been shown in multiple experiments to prevent injury. And I think that's the way it works. It's got nothing to do with the microcirculation or the large vessel vasospasm when you've got nimodipine. And I think that the outcomes just to treat vasospasm with a drug that just causes the vessels to dilate is very, very an amateur is one way to put it, or very unsophisticated is another way to put it, because it's so more complicated. If you look at the stuff we do now, I don't want to talk into details of the molecular mechanisms, but I think that long term, we just put in an NSF grant now for this this fibrinogen and the intracellular fibrinogen. I mean, that's going to change the paradigm. I think that if you can control CSF flow, and the way to control CSF flow for fibrinogen is we believe that changing the consistency of spinal fluid flow can just change the way CSF flows. So if you take water and you add sugar to it, it's going to change how it flows. The same thing. I think if the way the cells can release a little bit of fibrinogen can make it more viscous or less viscous, which then result in CSF flowing better or worse. I think that's part of the mechanism how this changes. So there'll be drugs we can develop long term that can change that, but we're not there yet.
Well, we thank you, Dr. Britz. That's all the questions that we have here. So we thank you for your presentation. It's generated a lot of excitement and enthusiasm among the neurosurgeons. It's really nice to see that someone is taking things to this next level of scientific inquiry and advancement and pushing this field forward. We're really excited by what you're doing.
Yeah, and I think for the young neurosurgeons, like yourself, you don't have to be a full-time scientist to do this stuff. I think if you're very focused and you enjoy it, you can have a small lab and make significant discoveries or significant changes. I think long term. I think that's the big reason I like doing it. I think for the young guys, they can see Gavin has, I have 3 people in my lab, but we're doing great science, including publishing something that's never been found before. So I think for you young guys, Mohammed, like yourself, you can do it, but you've got to be dedicated to keeping the lab going. Okay, I'm going to go back to operate. Thanks, you guys.
Thank you.
Enjoy your day. Bye-bye.